All right. Hello, everyone. Hello,
Hi,
hello.
everyone.
Hello.
Hi. Good to see you. Let's see who we got. We've got Andrea, Michelle, Megan, Katrina, Ashley. Awesome. All right. Well, welcome, everyone. Good. Very good to have you. Um, We've got a lot packed into a short period of time, so per usual. So I will go ahead and
But it
um,
said they might have
jump.
important information, so I thought, well,
Oh, I will go ahead and jump right in. As always, this session will be recorded, and then we will send out the link. So if you want to go back to something or you want to forward it to someone else, please feel free to do so. We'll start off with just a welcome and level set. So as always, we encourage you to update your name in Zoom so that we know both your full name and the organization that you're representing today. And then if you feel like it, our icebreaker to put in the chat for today is please share something you appreciate about your hometown or a place you used to live. And I know a lot of folks don't have one hometown. You've bounced around and lived in a lot of places, so pick one. I did this with a group recently and got some really fascinating responses and just a real diversity of things that people appreciate. So always interesting to learn a little bit about one another. And then please, this hour is meant to be interactive. And so use the chat, come on, talk to us. We're going to do a lot of discussion today. So we very much want you to be, participative and feeling comfortable to share your thoughts and input. And I see we've got walking and biking trails. Yeah, small town feel. Reading, that's awesome. Great. Well, thanks. Thanks for chiming in. And do we have any completely new people today? And I won't make you talk, but maybe maybe if you want to put in the chat if this is your first time. And Eva, we can go to the next slide, please. Just wanted to make sure that you have a warm welcome if this is your first time here. Just to reiterate, this is a space for regional stakeholders, so in the Northeast counties, that is, to collaborate, identify challenges, and problem solve. Our goal here is really of improving CalAIM implementation and driving and increasing the services that you all are able to provide for clients. So that is our goal. Thank you again for being here today. All right, and with that, I will pass over to Eva, who's going to walk us through our objectives and agenda for today, and then we will officially jump right in.
thanks, Gabrielle. So we just want to clarify our objectives for this session. By the end of this session, everyone will receive important updates about DHCS policy. We'll have a chance to discuss 2024 goals for the Northeast CPI, and we'll have some time to continue sharing feedback for DHCS related to ECM and CS implementation. So just to give you all a little bit more detail about how the session is going to go, obviously we're starting with some welcome and level setting. Then we'll move into resource sharing. We'll touch on the new ECM and CS implementation report. We'll get an update on client screenings and see some new features of the TA Marketplace website. Then we'll move into 2024 goal planning. And we'll have a discussion about the priorities and goals that you all have for this year within this CPI. We'll spend some time collecting that feedback for DHCS on ECM and CS implementation. And then we will have a few minutes to talk about next steps and share some additional resources.
All right, so jumping into our updates, most of which come from DHCS. So the first is pretty exciting. If you are not already aware, DHCS has made public a fair amount of data about ECM and CS utilization. So those links that are in that teal color where it says explore the ECM data here and explore the CS data here, in the slide deck that we send you after today's meeting, you can click on those and explore that data. You can see the data a number of ways. There's information on kind of just like the total number of members that are receiving ECM or CS services. There's information around the number of members that are receiving services for the different populations of focus. There's also some really interesting comparison data. So by with the member demographics, so race, ethnicity, primary spoken language, age group, and sex, where they compare overall MCP, like overall Medi-Cal membership, compared with who is using ECM and CS services. So that's really interesting. And then maybe most relevant to everyone are the utilization rates, or as they say, penetration rates by county and by Medi-Cal plan. So I really encourage you to take a deeper dive on that. And in the next slide, you can see that I've taken out just the data for the Northeast region. Now, one huge caveat on this data is that it is not current. And so it goes from January of 2022, so the launch of ECM, to June 30th of 2023. So we're multiple quarters behind. There's a data lag that's pretty significant. So I just want to say that, these are not the current rates. These are the rates,
And the
as of
successful.
Oh, these are the rates as of June of last year. That said, it's more data than we had before, and so we're really interested in looking at this and kind of seeing what else we can do with it. Um, so yeah, all right. So that's the data. I encourage you to look at it more, and we will continue to use this as part of our discussions as well. Then we can move on to our next update, which is around assessments and screening, client assessments and screenings. So at a recent meeting, DHCS asked us to remind everyone of some clarifications that they had made in October of last year regarding client screenings. So the first one is around the HIFMET, the Health Information Form or Member Evaluation Tool. As many of you may already know, the HIFMET is something that the Medi-Cal plan, it's a client screening tool that the Medi-Cal plans are required to get from every new member within 90 days of that member joining the Medi-Cal plan. DHCS clarified back in October that that is still required, but that MCPs can now contract with local providers to do that screening. And that if a member has an initial health appointment within the first 90 days of joining their Medi-Cal plan, that could be used in lieu of the HIFMET. This is relevant because one of the things that we've heard loud and clear from this group is that the administrative burden of all these duplicative screenings and duplicative reporting is really rough. And so wanted to highlight that this is at least one space where DHCS is listening and is trying to streamline the client screening process. For more information on that, we've included the link to the Population Health Management Policy Guide from DHCS. So if you have questions about that, I encourage you to look at the policy guide. And I would also imagine, not to put our partnership stakeholder partners on blast here, but I would also imagine that they likely know a lot more about the HIFMET and the various client assessments as well. Then the next client screening update is regarding the individual health education behavior assessment and the staying healthy assessment. So this essentially is that the reminder here is that this assessment was eliminated if a member again has that individual health appointment. This one is not 90 days, it's 120 days from enrollment with the Medi-Cal plan, so it's a little bit more time. And there are certain situations in which individual health appointment is not needed. So, for example, if a member was with a different health plan, let's say, and it's in their medical record from their primary care provider that that essentially that assessment has already been done within the last year, then it's no longer needed. So again, I'll let you dive into all the details there in the population health management policy guide, or ask the folks at partnership. But just wanted to elevate again, DHCS is trying to find some ways to streamline here. So. All right, and then our last update for today from DHCS is about the TA Marketplace website. And I will do a plug that we have office hours, and Andrea from Visions of the Cross will be joining us again for those office hours. Those are right after this meeting, so if you are interested, we are going to be doing a deeper dive on the updates made to the TA Marketplace website. But the short of it is that they have added some additional filters, which make it a lot easier to kind of nail down exactly for you to look into both the customized solutions that are available and as they call, off-the-shelf solutions. Again, these are totally free, not just free to look at, but free to have. So I really, really encourage anyone who hasn't already explored the TA Marketplace options to do that. Also, if you explored them months ago and found it overwhelming and confusing, that makes sense. It was not super easy to navigate. But with these additional filters, it's now significantly easier. So definitely encourage you to check that out. And again, join us for office hours right after this meeting if you want to do kind of a walkthrough and do kind of a Q&A on that. And it looks like Amber's saying, do you have a good number to call the marketplace for technical assistance regarding logging in? I do not off the top of my head, but I think that is definitely a good question and something that we can do some digging on. So thank you, Amber, for that question. We will get back to the group. All right, and I think that rounds us out on updates. Oh yes, one additional, not quite an update, but an expression of gratitude. I just wanted to give a huge shout out and thank you to those of you that shared your feedback in the recent participant experience survey that DHCS sent out. Oh, and Andrea, thank you for that phone number for Kyle for technical assistance. Super helpful. There we go. Um, but yeah, huge amount of gratitude. We recently received the results of that participant experience survey, and this was a survey that DHCS had sent out asking you all for your feedback on how this group is going and how we're doing as facilitators. And so we are currently looking at all of that feedback and thinking about how we can integrate that into future sessions. So really, really appreciate you taking the time to do that. All right. And if that was a little bit of information overload and you are just feeling like that was too fast and too much, we would love to talk with you offline. So Eva, Alexis, and I are available to do one-on-one conversations or join us during office hours. So please do not hesitate to contact us. We would love to have additional conversations with you, go in depth. And if we can help connect you with different resources, we will absolutely do that. All right, so that takes us to part 3 of our agenda for today, which is going to be a little bit more dynamic. So from here on out, it's less of me talking and more of us all thinking together. But part 3 is all about setting a goal for this group for 2024, for this year. So we can go ahead to the next slide. And this is part of, in our last session, we talked about kind of what you all as a group can expect this year from this CPI group. And one of the things that we have as a mandate for the first quarter is to set a goal for ourselves. Like, what do, in with this time, with these resources, what do we want to have accomplished by the end of the year? So that's what we'd like to spend maybe about 10 minutes doing a quick brainstorm of that. The idea here is that Eva and I will try to gather all of your input, and then we behind the scenes will try to put all that together and wordsmith it into a couple of goals, and then bring those back to you during our March session so that you can provide feedback on those goals and decide as a group what goals you want to take on. So we can go ahead to the next slide, which is really just an invitation on ways to participate in this discussion. So please raise your hand, speak up, voice over your thoughts. We'd love to hear from you. If you don't feel quite as comfortable doing that, please add your thoughts to the chat. That's a great way that we can also go back and have them. Or if you don't, if you don't want to share your thoughts publicly and prefer that they be anonymous, no problem. You can send me or Eva an email directly, and we will make sure that your input gets incorporated. And again, the goal here is to do kind of a brain dump, and then we will go back, wordsmith that into a couple goals, and bring those back to you next month for a decision. So without further ado, let's jump in. We can go to the next slide, please. All right. So in no particular order, I'd like you to think about how you would complete these sentences. So the first is what my organization needs in order to serve more ECM and CS clients is. And part of the background here is, we saw that those penetration or those utilization rates for most of the, or for all of the Northeast counties are, relatively, or I don't want to say they're relatively low, but they're lower than the estimate on how many members will be eligible for them, right? And so not to say that that you all haven't made amazing progress. In serving this region, given all of the barriers. But as we think about how we go forward this year, the question is really like, what does your organization need in order to serve even more people? Another question to think about is, in this region, a significant barrier to providing clients with ECM services is. So what do you need and what are the barriers that you're facing? And then really importantly, I come to these collaborative meetings hoping to what? We know that you have a ton of things on your plate, and many of you are working in very resource constrained environments. And so what is most helpful to you during this hour? Because we really want to form our goal for this collaborative around what is most meaningful and useful to you. So with that, I'll turn it over to the group. Again, please feel free to chime in or add your thoughts in the chat. But again, what does your organization need in order to serve more people? What are significant barriers that you're currently experiencing? And really, what would you like to achieve with this collaborative? What would be a good use of this hour every month for you? Give you some time to think and reflect.
Hi guys, I figure I'll say something. Why not?
Awesome. Thanks, Christina.
I like to talk. That's why I'm always here. So I'm probably going to go in reverse order because I'm unique.
Whatever you want.
Honestly, I love coming to these meetings because I feel like I get a lot of information that's super close to DHCS a lot faster and in a lot clearer way than if I was to just go and research and read all this stuff on my own. So that's something that's really nice. And I also get a lot of information out of best practices and connecting with other people inside of the community who are providing similar resources. And what's nice is that most of us are on the same insurance platform, I think.
Yes.
Everybody's
Yeah.
on the same one.
Yeah,
So,
everybody's with partnership. Yep.
which is great because anything that we're working on or as changes are happening and stuff, we're all going to go through the same change together. So it's really nice to be in that space together to, you know, tackle all of those challenges together. I'd say one of the biggest barriers to receiving referrals or providing anything for our participants is just how we identify them. You know, our populations of focus, and I bring up populations of focus all the time, but our populations of focus are not necessarily the most popular populations of focus inside of our community. And so making sure that we are really tackling the right people inside of our community and still addressing the needs of those individuals is a little bit of a challenge. Sometimes just finding the people that really need our help, because they usually don't self-identify them. Another barrier that has been coming up in a lot of conversations recently is duplicative services. So other services that are provided that are considered, you know, duplicative. So we can't have them in this program and this program at the same time. There's a lot of people who have hesitancy in referring over to ECM when they don't fully understand it. Versus like MSSP or any other waiver programs that are out there. And then vice versa, right? People who are like, well, ECM is getting so much attention right now, so we should just send everybody to ECM, and then those other programs are suffering. So as you guys know, I'm all about the person and who we are serving to make sure they're getting the right services. And so if, you know, it makes more sense for them to be on a different waiver program, then that's what we really want to encourage. But there's such a lack of information about the differences between the different waiver programs and what, you know, the pros and cons are, that it's a big challenge when we do serve a lot of those different programs here at Connected Living. And then I think in order to serve more people, you know, one thing for us, we really have to build out our policies and procedures a little bit better. Like we've been doing this a little while now, so we're kind of getting the hang of it and starting to build some of those efficiencies. So what we really need to do is just making sure that we are doing things the most efficient way. And I get a lot out of this group to figure that out, along with just documenting it and making sure that all of us are following the same path and not going whatever which direction to get as many people as we can as possible. So that's Dignity Health.
Yeah, thank you so much, Christina. I have a couple follow-ups if you don't mind. So one was in terms of, I think that point about people figuring out whether to refer to ECM or MSSP or a different waiver program. And it sounds like just lack of, from what you're saying, that lack of information about how to differentiate them and how to know who to refer where is part of the issue. Would it be, or would having some kind of like decision tree or like like a guide of if this, then that, have you seen that anywhere? Or do you think that that might be helpful? Because we can kind of try to see if anybody in the state has already created something like that.
Possibly. I think it's more just a matter of education of which program is what. So the participant really is the one that can make the decision that's best for themselves, right? Okay. There's so much information that's going out about CalAIM all the way across the state that it's overshadowing a lot of those other types of things. And so if CalAIM is the best spot for them, then absolutely I want them to make that decision with confidence. And then the same thing for some of the other programs. And I think it's causing a little bit of angst between providers of service as well, because there are some MSSP sites. I just got back from an MSSP statewide meeting, so that's what's on the top of my head right now. But there's some angst between the MSSP sites and ECM sites, feeling like they have to compete with each other to take care of these participants, when ultimately, first of all, it's participant decision. And second of all, like, what is going to be the best service for that individual? So there's just not a lot of information out about the other waiver services. And I think a lot of times participants get stuck in the middle trying to battle between two providers, and that's not helpful for anybody. And so that was my main comment behind that is it's not necessarily as much of a barrier for myself as we are MSSP and ECM providers here. But at the same time, I'm hearing it a lot in the community. So that's one thing that I wanted to bring up. I hear it inside of our adult day healthcare meetings. I hear it inside the MSSP meetings. I hear it in so many different collaborative meetings that I go to, that it is a barrier for providing care for people because of the fact that they don't know which program they should be on, and providers are just so eager to put more people on that they aren't focusing on the participant either. So
got it. Thank you for that clarification. No, that's super helpful. And it's funny. My other follow-up question is pretty much exactly what Andrea just put in the chat, which is, if you're looking at needing to document or write policies and procedures, the TA marketplace can give you some free resources for doing that, and some bodies to help with that. So yeah, with definitely something we can talk about during office hours or offline.
And we just applied for TA assistant specifically
Yes.
for that because of Andrea, your presentation that you did when we did the in-person meeting. That really motivated us to really go to the TA marketplace, because before it was so confusing. Like, you go to the TA marketplace and there's so many options and so many things in there that I didn't know what I was looking at. But when I was listening to your presentation that we did back in December or November, whenever it was, that really motivated me and other Dignity sites to actually investigate a little bit more into the TA marketplace. So we just got our contract with somebody. Don't ask me who, because I forgot, but we are in the process of going in that direction.
Awesome. That's such good news. That's great to hear. Thank you so much, Christina. Amber?
Yeah, hi. I was gonna, so for me, kind of same thing, but different. So for my organization, what we're looking at is really just expanding the target, the populations of focus that we work with. I think that's kind of where we're at. We've done pretty well at being able to balance internal referrals and external referrals, but I think we just need to kind of broaden our pool a little bit. Something similar to what you were talking about in terms of duplicative services. What we're running into is just a lot of different agencies all going for the same population, and just needing to coordinate a little bit better locally who is providing each service and who's going to be a better fit for the individual. Like I learned last week, we have somebody sitting at the mission 3 days a week, enrolling people in ECM, and they do telehealth services for their ECM, whereas like we do in person. And so that might be like a better match. But I think because there is just kind of an oversaturation in the market right now of what ECM is and who does, people are just kind of defaulting to who they have relationships with to start it up. I know Andrea and I and Samantha and I, we've recently had good conversations about trying to really look at like who can best serve the client and being more strategic around that. So we don't have individuals just like pinging around programs, whether it be for a CS service or an ECM service. And sometimes a barrier is we do still have, especially the folks that come through my medical respite program, we still have a good number that don't have partnership health plan. And so the length of time to get someone signed up for partnership and approved, we can lose them, because when they're in med respite, we have them like locked in, we can work with them, but after they leave there, we do lose them. And so sometimes that turnaround is just really rough. And yeah, that would be the answers I have right now.
Great. No, those are really, really valuable. Thank you, Amber. Doreen?
Yes, hi everyone. I'll go in reverse as well. I come to these collaborative meetings. HINC is a membership organization, so we have health centers and community partners out in the very, frontier and rural areas. And the uptick for ECM and CS, this program has been slower. So we've been really working at sharing best practices with our other health centers that have been implementing this model for a while, and to kind of figure out the staffing patterns and how to make it work. I think a significant barrier to providing, clients with ECM and CS services, if you're in Bieber, California, or McLeod or whatever, you're not going to have local CBOs providing some of this, community support services that are. So I really feel that there's an opportunity to really name what that model looks like. I think we've discussed on a few calls, in some of the outlying areas, they have more community resource centers or family resource centers. And could those be bolstered to basically centralize some of the community support services that CBOs may, provide in Reading, but, they would do it in an outlying area 1 day a week, or if in Siskiyou County, they would centralize. I know Siskiyou County has, they used to have 10 family resource centers. I know a couple of them have closed because of lack of resources. In Bernie, Tri-County's community network closed, but the hospital took them under their wings, so they're getting their legs back. But if you're in those areas and you have some, clients or patients that need support services, we have to somehow centralize or make it easier for the agencies to provide those services, as well as the clients or the patients to access them. So that's kind of my thing.
Yeah, thank you, Doreen. I think that piece about uplifting, that there's an opportunity to name what that model looks like and really make that clearer and more easily able to be replicated is really valuable. So thank you.
It wouldn't take a lot of resources to, to really, help some of those community resource centers or those centers in those regions. So, yeah.
Great. Thank you. Anyone else have thoughts on either what they'd like, why they come to the meetings and what they'd like to see in the meetings, or would like to uplift additional barriers that that haven't been covered yet? I think we hit a lot of the big ones, so.
I shared in the chat, but I can talk out loud about it. So for visions, some of our biggest barriers is actually internally. So a lot of our counselors have a hard time collaborating with our ECM and CS personnel. I feel like they think maybe it's additional work that they're having to do. So we're trying to streamline and work with our TA vendor to kind of for our vendor to go around and do kind of interview our employees and see where the barriers are and how we can make things run smoother internally. So that's something that we're working on. And then I would say that we need more staff and more direct referrals in order to serve more members. And then we would also need more space too. So it's always just an ever-flowing pattern of, okay, well, we need more capacity, and then we need more staff, and we need more referrals. So it gets to a point as, where's your cutoff line, like how many members do you want to serve? So I think that once that's established, you can kind of set, your goal as far as, okay, well, this is how many members we're going to serve, and this is how we're going to get there. But as of right now, I think that growing so quickly, that internally is where our biggest struggle is right now, to be transparent.
Yeah, thank you, Andrea. And, I think that's such an interesting additional piece, right? Because anytime, as an organization, we all know that anytime you bring new people in or you change a program, the people working there have thoughts and feelings about that, right? And sometimes really different priorities and really different things that they want to bring to the work. So, and those internal barriers are very real, or they can be very real. So thanks for elevating that, because I think you're probably not alone in experiencing those.
I hope not. Thank you.
Okay. All right. Well, any other thoughts on this? Okay, well, if you think of something, particularly something you'd like for us to incorporate into the goal for this group for this year, please send us an email. We'd love to hear from you. And so to wrap up this discussion, I just have a little poll for everyone, which is, we can kind of go two directions within our goal setting. We can either set a goal that's around the outcome. So for example, increasing the ECM penetration rate, or how many people are using services, by X% by the end of the year. Or we could focus more on a process goal for the group, which might be something more akin to, getting X percentage of contracted providers to be participating in the group. The benefit of a process goal is that it's a little more within the scope of the group. It's not so contingent on things that are happening externally. On the other hand, it's less inspirational. Like, people don't tend to get really that excited about process goals. The nice thing about an outcome goal is it gives you a really, powerful thing to move toward, like reaching more clients. But it also means that there are a lot of things that impact the region's ability to meet more clients, not just what we do in this group. So those are kind of just some pros and cons. But I'm curious, for folks, if we were just going to do one goal, whether you'd rather have something around client outcomes, or whether it would be more process oriented. So I'll give you a second to voice your opinion through the poll on that. And thank you, Andrea, for adding in this goal idea, always into a concrete solution or recommendation. Great.
Gabrielle, can you remind me what you're using for the ECM penetration rate? Is it
So currently the data,
assignments or providers, or what are you looking for?
yeah, absolutely. Well, so this group can kind of decide that. The data that we have is the data that DHCS made public. And so it's a super crude and simple percentage of the number of people receiving ECM out of the number of Medi-Cal members in that county. So it doesn't take into consideration how many people they think are eligible for ECM. It's literally just how many different people receive services in the time period, and how many people have Medi-Cal in that county. And so it's, now if we have access to other information, absolutely, we could be, we could
Wouldn't that
have
be
that be
really
different.
hard to evaluate? Because the percentages eligible, I think, is 1 to 3%. And that's going to be a hard number to move because it's so small.
Yeah.
So I just wonder if that's the right thing.
Yeah. No, I think that's a really fair critique. And I think personally, one of my concerns about having an outcome goal is that there are just so many things that would influence something like that are outside the scope of this group. And so in some ways, it may make more sense to focus on what would this group like to achieve in a year? But wanted to put that to you all and see if you had thoughts. So thank you, Doreen. That's really helpful. Great. And Eva, do we have have enough come in? Okay. So 60-40. So we're pretty split. So with 60% of folks preferring an outcome goal and 40% preferring a process goal. All right. Well, we will come up with some options for both and present them to you at our next meeting next month. All right, so today is the last day of a series. Those of you who've been with us for the last several sessions this will be familiar. which is we are rounding out our discussion, gathering feedback for DHCS for the questions that they asked about their 6 priority areas that they had set out for this year. So we can go to the next slide, please. And maybe click it. Yeah, there we go. So DHCS, just brief refresher, DHCS had set out at the beginning of the year these 6 levers, essentially just priority areas that they'd like to focus on for the year. And they have a series of questions for each priority area that they are wanting input on from these CPI groups. So in our session last month, we talked about levers 5 and 6. And so our goal today is to round out with levers 1 through 4. We already had the pleasure of talking with the Shark ICC group about levers 1, 2, and 3. So thank you to those of you who were on that call. And so here we're going to summarize what we heard from that and use that as a basis for a discussion if folks have any additional feedback that they want to make sure gets to DHCS around levers 1, 2, and 3. And then we'll also do a little discussion of lever 4. Hopefully that'll round us out. We'll be able to both share back that feedback with this group and importantly also send it to DHCS. So that is the plan for the next 20 minutes or so. All right, so again, let's see, Eva, we can go to the next slide. So again, just an invitation to raise your hand, speak up, use the chat, or send us your feedback by email. All of this feedback, no matter how you share it, will be anonymized, so none of it gets tracked back to you when it is shared with DHCS. So please be honest. All right, so we're going to go backwards a little bit and start with, and we can go to the next slide. Yeah, we're going to start with lever 4. Which is around expanding provider networks and streamlining payment. So the overarching question from DHCS is what strategies or approaches have been successful in promoting contracting? And then their follow-up questions are, what is your feedback about rates discussions with PHC? Are rates a major barrier to contracting? Now, I understand that PHC is on this call, so that may or may not be a question that you feel comfortable answering in today's call. Feel free to send us an email separately on that one. What input do you have about workforce capacity? What ideas can you share about strategies for growth, including the community health worker workforce? And then, are you seeing gaps in ECM providers available to serve pregnant or postpartum individuals with severe mental illness and substance use disorders? And I think that DHS is asking that because in some regions they are seeing a gap there, and so they're trying to identify whether that is a relevant gap for this region. So again, we can start anywhere in here. Yeah, Doreen, you look like you have something you want to
I'll jump in about the contracting. It's standardized with partnership. The rates are standardizing. So I don't know. I mean, I think we've given feedback about some of the costs, you know, I know from the Shark ICC, but partnership, it's standardized. So I don't know if there's really no negotiation there, because it's, if you agree to do this, this is what you'll be paid. And so I don't know about that's relevant.
Okay. Thank
That's
you.
just my opinion. So I don't know. And I don't think the rates are stopping anybody from contracting. I think those who have, and I know Amber's got her hand in the queue, but and then that we came out of the whole person care pilot. There was some transition there, but I think we've worked through quite a few things. So.
Okay, great. That's really helpful context. Thank you. Amber?
Yeah, I don't feel like rates are a major barrier to contracting. I think one of the things, and this kind of goes into workforce capacity. So I think it depends on how you're setting up your ECM model. So, and this also goes to community health workers. And I also just like want to call out community health workers can mean like a whole bunch of things. So there's like specific guidelines to if you're using it as like outlined by Department of Healthcare Services, what a community health worker is. And then that can be, it's like social worker, right? Like I'm an LCSW and I'm a social worker, but other agencies, you can be a paraprofessional and still be called a social worker. Both are true, right? So I think when we're talking about community health workers, how you're setting up your workforce capacity, it depends on what your model looks like. So some folks are doing a model where it's like primarily telehealth, like they do phone calls, you know, throughout the month, they check in with people and maybe a minimum of one time in person. That workforce capacity is going to look super different than like my expectation for my team is everything is in person. Like we're going out into camps and doing outreach. Like, so I have to do a lot of work around secondary trauma and safety and training and things of that nature. So I think that's what's great about the TA marketplace. The few limited times I've been able to get in is it can speak to both. Across the board, you have to know that if you are going to choose to go with like a social worker direct BSW, MSW, LCSW clinical model, your rates are probably not going to compensate for the work that's being done, right? If you're going to go with a paraprofessional model, then your rates are probably going to be able to like support a larger workforce to do it. And you're going to really need to invest. Like I made a leadership decision to not have requirements around diplomas and whatnot so that I could build my workforce up. But it's a heavy investment and it can lead to turnover because what people think it is and what it is are two very different things. So that would just be, you know, community health workers are great, but also like, look at what the code says around what's needed. You need a doctor who's going to sign off on those care plans specifically. And then, you know, so that whenever you start pulling those sort of things in, you're tapping on other people to make it happen and everyone's really impacted. And then just so everyone's aware, HOPE we do ECM with pregnant and postpartum individuals. So if you know someone in the area who you feel like is a good match, I will share though, and I would like this shared with Department of Healthcare Services, individuals who are pregnant and postpartum with severe mental illness and substance use disorder. The traditional ECM model is not compatible with individuals who are often traumatized by child welfare intervention and are struggling with stigma around severe mental illness, being postpartum, and having a substance use disorder. So we do it, but we do it like our care plans are super modified. Everything is really toned down because that population is very much stigmatized. And like if you're working with someone who is postpartum and has severe mental illness, their capacity is super low. So just to be, again, it's that thing of like, we want providers out there, but they need to be prepared to work with the population and what they need. And that can sometimes be a shift.
Thank you so much, Amber. To go back on, could you, sorry, I'm just looking at my notes. I'm curious, you were talking about the different models. And you said that it requires a heavy investment. You said that you had chosen not to require diplomas in order to
high school diploma. I don't require a bachelor's or a master's for my care coordinators.
Got it. Okay. Okay. And when you say it's a big investment, meaning a big like workforce development investment.
Mm-hmm. Yeah, you need to be prepared to like teaching people about like motivational interviewing, engagement strategies, you know, mental health first aid, how to navigate systems.
Yeah.
Andrea's point before about like those basic things of like, I need my group to understand that if I go and communicate with everyone ahead of time, that saves me time, right? But it feels like, well, why do I have to go talk to this person?
Mhm.
Like, you know, those sort of like those things that you might get from a higher education, which are super beneficial. Like also you have, if you're going to be doing that, hiring
Yeah.
people with a bachelor's or master's, like you're going to need to compensate them more.
Yeah. Yeah. No, it's
So if
super.
I could piggyback off this
Yeah.
conversation, I think there's a real challenge with community health workers, paraprofessional case managers, as we call them, or care coordinators, and now wellness coaches that the schools are going to be able to use to do some of the same navigation. And I think we need to get clear about all the skills and the responsibilities and roles in each of those classifications. And I know we have a case management certificate program at Shasta College that our Shark ICC you help to develop the criteria on that. We're actually my workforce group is meeting right after this meeting, but we're going to be looking at pulling job descriptions for each of these classifications and see if there's something we can do to work with Shasta College to do more of a certificate program to help, you know, like Amber's point of training up. Is there some core competencies that the college could do? I mean, that's the win, because community health worker, CHWs have been around for years. I mean, 30 years. They have, all the training's been all over the place. There are some roles or kind of efforts to kind of standardize it, but it'd be great if the community college, you know, system could be the ones developing some of those trainings. So everybody's not doing a hodgepodge, you know, even in with the health plan. So anyway, I just want to say, we call these things all different job titles, but a lot of them are the same functions, and we got to get clearer about who does what.
Yeah, no, that's well, and I'd love to hear more at some point during, particularly if you want to share more at some point with this group around the work that Shark is doing in comparing those job descriptions and working with the community college, because that sounds really interesting. Yeah, great, thank you. Debbie, I saw you go off mute, or yeah, off mute. So I just wanted to see, did you want to share something?
I, of course, was going to fortify that partnership does do the same across the board as far as rates. We did go with the mid-level, and we realized that in some cases that is, I don't think in any case it's ever going to say it's plenty, but we do feel that it covers the services and they're being utilized properly. You know, we don't get any reimbursement for these services yet, so that's why we have to be careful with the bottom line and the taxpayer dollars. But we do hear when people let us know, and that's why our ECM rates did go up. But as far as community supports, we did not raise those rates, at least at this time.
Okay, great. Thank you for sharing, Debbie. And I guess, Amber, a follow-up on that rates question is, maybe you had mentioned that if you're doing that, you know, kind of more intensive in person in the community, maybe with licensed, you know, providers, that model, that the rates will not cover the cost of services. And so I'm curious, do you braid funding with other grants, or how do you make that sustainable?
So I think that the rate that I get for ECM right now and community supports is reasonable given the services that I provide.
Okay.
I do. I think that partnership and Department of Healthcare Services have been really open to like feedback around it. I think I would agree with Debbie's words around like, is it enough? Like, you know, but can it cover the job? Like, yes. So yeah, I'm always looking at braiding other funding, because this is taxpayer dollars and also what my patients need. So for instance, one of the things we're working on with another funding source is like helping homeless individuals take care of their animals, right? Because I know that's a needed service, and
Yeah.
the funder knows that's a needed service, and it's a barrier to accessing healthcare and housing. And those are also like tricky things when you're talking about it in the public, because everyone has like value associated with it, right? So I think everyone should always look for other ways to like fund their programs. I think that's there, because there's always gonna be a creative need that the patient needs, but you know, it's gonna be a hard sell.
Yeah.
I think that when you start making the work harder, where you ethically should probably have individuals who have like some form of, I'm going to use the word clinical, but I don't mean it in like an MD, NP, PA, so LCSW sort of way. But when you're doing more of a heavy lift with harder populations, right? So severe mental illness and substance use disorder, those are tricky. Like those are super tricky. And there's, especially with the fentanyl crisis, in our country, like there's high risk associated with it if you don't land it well. So I think whenever you start working in that area, where you probably should have folks that have, in addition to like good human stuff that makes them a great candidate, maybe some educational support, I think then you do have to look at compensating them appropriately for that skill set. And that's where it gets tricky.
Got it. Okay. Got it. Thank you. Thank you very much for that clarification. All right, Andrea, real quick, and then we'll wrap up.
Yeah, I just couldn't agree more with Amber in regards to expanding the ECM and CS providers, is that not everybody is meant to deal with these populations of focus. So that is the biggest barrier that they're going to face, is that maybe offer those trainings for these providers in order to how to communicate and interact with these populations of focus. Otherwise, you're just going to see the same providers in the game.
Yeah.
Thank you.
Makes a lot of sense. Thank you so much, Andrea. All right. Well, this is super fruitful per usual. If we go to the next slide, Eva, I just wanted to wrap up by letting people know. So this is, and again, no need to read all of this in 2 seconds. We will send out these slides. But these were some of the highlights that we took from our conversation in January with the Shark ICC group. So if folks have a minute, once we send this out, to look through that and just let us know kind of whether that reflects your thoughts as well, or whether you have other or differing thoughts. Our goal is to package all of this up in the next few weeks and send it off to DHCS and reflect it back to you all as well. So if you have additional takeaways on levers 1, 2, or 3, please email us or find some time to reach out, because we want to make this as comprehensive as possible. And with that, I will hand over to Eva really quick to take us through next steps.
Thanks, Gabrielle. As always, we just wanted to get everyone's quick feedback on which part of today's session was most valuable. So if it was the updates from DHCS, discussion on drafting a 2024 goal, or discussion on local feedback for DHCS, please give us that feedback. It's helpful in making sure that future sessions are valuable as well to you all. So I'm just going to leave that open for another second or two. And it looks like the discussion was the most valuable for folks. I know that was a really rich and helpful conversation. So thank you everyone for your engagement. So prefacing session 3, we'll send out that registration link in the post-event email for the March session. So please use that link to register. And as we have been doing, we'll send you the Zoom link right before the session takes place. Continue working on your PDSA. And as always, we're available for one-on-one support. And speaking of additional support, office hours are taking place right now. So please feel free to jump on over to that Zoom if you have a little bit of time and want to join us for office hours.